Episode number 241 of the Wholesome Fertility Podcast. My guest today is Dr. Ellen Goldstein. Dr. Goldstein obtained her MD from Mount Sinai School of Medicine in New York City and is a double board certified OB-GYN and reproductive endocrinologist. She has guided her patients through more than 1,000 in vitro fertilization cycles and consistently delivers some of the highest pregnancy rates in the industry. During her time as reproductive endocrinologist and infertility fellow at UCLA and Cedars-Sinai medical centers, Dr. Goldstein published and presented internationally her revolutionary discovery of an important genetic mutation that causes what had previously been considered an unexplained cause of familial infertility. In an industry that is continually becoming less personalized, Dr. Goldstein is proof that you can provide world-class fertility care and empower hopeful parents to choose a fertility journey that aligns with their goals before anything else. She weaves her way through the often overwhelming world of fertility care with intuition and empathy to make sure her patients have a clear understanding of their diagnosis and treatment options. Welcome to the Wholesome Fertility Podcast. I'm Michelle, a fertility acupuncturist here to provide you with resources on how to create a wholesome approach to your fertility journey. Welcome to the podcast, Dr. Goldstein.
Thank you so much, Michelle. I'm really grateful to be included and happy to be here.
So I'd love if you can share your background, introduce yourself, and how you got into the work that you do.
Sure. Well, I think that this field kind of found me. You know, when you find your calling, it's just truly the best gift in the world. I never feel like I'm working a day in my life. I get to go to work and hang out with my friends is really how I feel about all of my patients and the families that I help to grow. I've always been interested in genetics and molecular biology and sort of finding the basic building blocks of how things work and being able to address things at their root cause. And then when I was in medical school, I thought that I was going to pursue a field actually in the field of medical genetics, which is a fascinating field. But, you know, one of the cool things about medical school is getting to explore which patient population and groups of people that you really fit in with the best. And what the people that I love to take care of were the young women on my OB-GYN rotation. And also what's cool about medical school is you find the group of doctors that you fit in with the best. And I really felt that the OB-GYNs were my tribe. And so that led me down that path. But then, you know, to be an obstetrician, gynecologist, and as you know, is a very difficult life. Like they work all the time doing incredible work, up all night delivering babies, never being with their families. And I found this perfect niche within this field where it's the OB-GYN patient population, you know, the very bread and butter of gynecology, like helping somebody get pregnant when they can't, but also with that molecular biology focus and all of the genetics and the science that we get to work with on a day-to-day basis, and also just getting down to the very basic building blocks of what makes a pregnancy and what makes a life. And it's just been the perfect combination of those factors for me.
That's awesome. Yeah, I feel the same way. I think it varies with so many different backgrounds and different types of practitioners, but all of us feel called to this in some way, on some level. And it is miraculous. The whole thing is miraculous. And I remember going sometimes with transfers. I'm sure you've seen acupuncturists come in and we do like the before and after. And I'm floored every time. I'm like, oh my God, it's just incredible to see this miracle happening with technology.
It is an incredible field. And when it's done right, it works so beautifully. And it's just such an incredible place to be, like riding this wave of the science and the technology and the patient care.
No doubt. So one of the things we talked about in the pre-talk, and this is actually something that I feel is really important for people to hear, because just because you're studying and you became a reproductive endocrinologist doesn't mean that you do what every reproductive endocrinologist does. Everybody's different. That's why it's important to really try people out and see what fits you best, because not everybody goes about it in the same way. And you spoke about doing a less invasive cycle. So talk about that. Talk about the difference between mini and just like really the whole thing, because a lot of people are very curious, like, what is mini IVF? What does that mean? Is it something for me? And then also the natural cycle
Yeah,
embryo
sure.
transfer.
So that's what's really amazing about the field of medicine, is that we can and that we're allowed to find the art side of this, and the side of this that works for us and for everybody, has room to practice the way that they have found to be the best for their patients. And certainly I think that the way that I do it is very effective and the patients really appreciate it, but I may not be for everybody, and the guy down the road may not be for everybody, and you have to find the right, this is a relationship that you're going to be on a path with your fertility doctor for some time, hopefully not longer than necessary, but for some time, and you need to make sure that the relationship works for you and that you feel heard and understood, and that you are an equal partner in this team, you're taking care of yourself just as much as they're taking care of you. And so you really want to make sure that your doctor's rationale for how they do things makes sense in your head, and that they're not doing anything extra. What I have found is that by providing a highly personalized level of care and really just honing in on exactly what the patient or the couple in front of me needs, I'm able to avoid a lot of unnecessary things. So for example, something as simple as the contribution of the uterus or the endometrial lining to a fertility treatment cycle. For me, look, it's an incredibly important part of your treatment, but I'd say probably 60% of people have a completely normal uterus that never needs any further evaluation or anything done to it. So certainly many people who walk through the door of the fertility office are going to need something like a saline ultrasound or a hysteroscopy or some kind of evaluation of the uterus, but many people will not. And so why do it on everybody? So if you can tell that, and with a high level of confidence, that this person's uterus is normal, why go down the road of exploring it if it doesn't need to be touched? And so because I'm doing all of my own ultrasounds myself, if I see a normal uterus, that's it. I mean, unless they start having failed treatment, until, which is rare, honestly, if you do a good job, then you go exploring. You don't need to be doing a saline ultrasound or a hysteroscopy on every person who walks through the door. And that is a moneymaker for your doctor, a high risk of false positives. Saline ultrasounds have high risk of false positives. So if you have a saline ultrasound and a little ditzel is found, and then you go to hysteroscopy, and then you've paid all this money and wasted all this time for something that didn't need to be done. And so I'm really trying to avoid things that are unnecessary. And that is, I walk that line at every step of treatment that I do, and the way that I think about for people. So let's talk about sort of mini IVF, natural cycle IVF, natural cycle frozen embryo transfer. So when you hear about mini or natural cycle IVF, that is a marketing term. That is not a medical term. There is no definition of mini or natural cycle IVF. Does it involve no medication? Does it involve Clomid? Does it involve just low doses of injections? All of those things qualify. What it really means is that your doctor is intentionally using lower doses of medication than maybe we were sort of traditionally taught to use. And in my mind, people do it because it sounds good. It's a good marketing trick. And also your and then the other thing the doctors do is that it turns into minimal attention IVF. So rather than watching the patients closely, they'll be like, here, take these low doses of meds and come back in a week. When I would start looking at somebody after only 4 days of medication, because there's a lot that you can learn and a lot that you can adjust. So I've seen they have to cancel, or the cycle doesn't, and then the cycle doesn't go well. And it's actually been a good study. You've heard people have this experience.
Yes, some of my patients, and it's very frustrating because they're going through all these. Well, it's usually not with a mini though, just in general, right. It's missed, and they don't see them enough.
Because what's happening is the doctors are like, well, if we're going to market this as lower cost, I'm just not going to see them as much. And then the other thing is that it has definitely, there is good scientific data out there that shows that it has a lower success rate than a traditional IVF cycle, because IVF is a numbers game. And if you are someone who is lucky enough, and we're going to talk about low ovarian reserve also in this podcast, but if you are someone who has normal or high egg numbers, you are lucky and you need to let those egg numbers work for you. Because IVF is a numbers game, and the more eggs you grow, the better your statistical chance of having a normal one, no matter what age you are. But of course, as we get older, we're much, we have dwindling proportions of normal eggs. And so the higher numbers are better. So if you intentionally give someone lower doses of meds than what their ovaries are going to respond to, just because it sounds good or it looks good or it costs less, or, the patients are asking for something less aggressive, you are not doing them any favors with their fertility treatments. And so IVF protocols should be highly personalized. Now, that being said, I certainly do low and medium dose protocols on people all the time. I'm not blasting, and probably like at least half of my patients over the age of 38 or 39, I'm using less than maximum dose meds, but I'm doing it intentionally. And my goal is still to get as many eggs as possible. And it works to get as many eggs as possible because many people don't need the max dose meds. But many people do well with the max dose meds. It's about choosing the right person and the right protocol for which person to maximize the number of eggs retrieved, because that really is what gets you a higher success rate, is having the best response that your ovaries are capable of doing. And so, I've seen really bad things out there, like people with tubal disease. So if you have blocked fallopian tubes because you had a bad appendicitis, or you've had bowel surgery, or you've had a pelvic inflammatory disease or chlamydia, if you have bad tubal disease, but you have normal ovaries, don't let somebody tell you, oh, you only need one egg at a time, let's do a natural cycle IVF. Well, you'll spend $8,000 or $10,000 to get your one egg retrieved. And each one egg is like a 7% chance of a baby. It's like, so if you're somebody with tubal disease, you actually have such a good chance of success with fertility treatment as long as you get your tubes removed. You cannot have, so I have seen people do a natural cycle IVF to get one egg out of a 33-year-old who had normal ovaries, who, would have made 18 eggs with stimulation. And then they looked at her ovaries with a surgery, actually did the surgery, looked at the tubes and didn't remove them. And if you have dilated tubes, they need to come out. So like, it just, the amount of like stupidity.
So why is that? So people can hear that.
So dilated, if you have damaged fallopian tubes, not only are they not helping you get pregnant, they are hurting your chances of getting pregnant. So if you've had some of the worst, I've seen bad fallopian tubes from, we know chlamydia, pelvic inflammatory disease, also have seen it badly in endometriosis, also in people who've had childhood appendicitis, have badly damaged fallopian tubes, because that inflammatory process is going on right next to the tubes and it damages the tubes. They're very delicate.
Right.
And so, if your tubes are dilated, well, you might say, well, I'm going to do IVF. I'm going to get eggs out of my ovaries and I'm going to bypass my tubes. Why does it matter what kind of shape my tubes are in? But if your tubes are dilated, they're full of like just this noxious fluid, and that communicates with the uterus. And so you actually transect them at the connection to the uterus. And now you've got this uterus kind of hanging out on its own, but that's fine. It doesn't need to be connected to tubes. It's okay. So what I'm describing is somebody doing the wrong treatment for someone on so many levels, like she had normal ovaries. She needed to have a normal stimulation, get lots of eggs out to give her the best chance of success. She needed her tubes removed. And instead they were like, oh, you have dilated tubes. Who cares? Also, you only need one egg at a time. Not true. So like, it's,
But you did mention that after 38, 39, you do lower dosages. And I have heard that sometimes can yield better quality. Is that correct?
That is something that does not. So that's an interesting question. Everybody's worried that the super high doses of meds are damaging the quality of the eggs.
Mm-hmm.
That may be true with non-standard high doses of meds. So one thing that you should know is that the maximum dose of medications that has been studied in fertility protocols is 450 units total. So you will sometimes see doctors use 600 units per day total. That's a lot, or more. That's a lot of medication. So 450 total is like a 300 of Follistim and 150 of Menopur, which would be like my maximum dose protocol. But you'll see people going 450 plus another 150 or 225 minutes. These are high doses. And could these potentially fry the eggs? Maybe. I don't think it's the meds that's fry. I don't like it. Actually had very good evidence that the high doses of meds do not damage egg quality. I think it's the not paying attention. I don't think it's the meds themselves. I think it's choosing the wrong protocol for the patient in front of you.
Mm-hmm.
And so you're right. In somebody who's 38, 39, 40, who has low to normal ovarian reserve, I do tend to go lower than that 300, 150. Absolutely. I tend to go 225, 150 or 150, 150. And then if they have very low reserve, if their AMH is below 0.5, and I counsel them that they're going to have only that they'd be lucky to have 2 or 3 eggs retrieved, but we got to give it a go. We got to try it. We got to see if we can get lucky. Those people could even do super low dose meds, 75, and those eggs will grow. You do not need to, if all
because it's so few, it's not like you're taking a bunch that are competing with it because it's so little. So you don't need it, is basically what you're saying.
You don't need it. They're going to grow. If those eggs are capable of responding, because this is the other thing, not every follicle is capable of responding. You can't count every follicle you see on ultrasound and start naming it Bob and Henry and, Jackie. Like, you can't name your follicles because you're not going to necessarily get a egg out of every follicle.
Right.
Because if they can't grow, they can't grow. And so if they can grow, they will respond to lower dose meds. Absolutely.
Yeah.
But
interesting.
if you're lucky enough to be 40 years old with an AMH of 2 or 3, then you have found yourself in a good situation egg numbers wise, and you should do higher dose meds and let the numbers work for you.
How do you know exactly what protocol to do, or is it something that you see kind of like because you can't really predict how people are going to respond? Is it something that you kind of shift as you go? Because most people, they need more than one cycle.
So that's the art of fertility treatment. And what you will find when your doctor devises their first protocol attempt for you, it shouldn't be one size fits all. It's very much based on their own professional experience, their own, hundreds and thousands of cycles they've done in the past, people that have looked similar to you, different factors about how your particular ovaries look on ultrasound and in your laboratory results. It really is an art. I mean, I'll tell you, I pluck these out of my head when I see people. And it's not always, it's different each time. And so, and then you are correct about, do you learn from a protocol when you do the next cycle? And so the other thing that people should understand is that this is very much an art form. There is no one protocol that works the best for everybody. And I'll say that I'd say probably 70 to 80% of the time, the protocol that I choose the first time turns out to be what I think would work the best for the patient. And either it works and they have their baby, or the cycle goes great. They just don't get that normal embryo, or they don't get what they need from that cycle. And I do the same thing again if the first cycle went well. But that 20 to 30% of the time, you learn something and you change it. And I think a big part of an IVF cycle is how you lead into it. Do you do no pretreatment? Do you do estrogen pills? Do you do birth control pills? Do you do a luteal phase start? That's a huge part of the art of this. And every so often we get totally surprised, like I don't usually use birth control pills in people with low ovarian reserve. And I had somebody who on her second or third cycle of she was a warrior. I really didn't think that this was going to be a good treatment for her. And she was like, no, she wound up doing 4 cycles. And each cycle she got 1 normal embryo. And we can also talk about like fresh embryo transfer, because I had said that she should do fresh embryo transfer, but she was, a lot of people get very swayed with this online. She really wanted to do the genetic testing and whatever. So each time she got 1 normal embryo, and in her second cycle, just for timing purposes, she was out of town or something. I was like, well, I guess you can take birth control pills. And like, I totally, I kind of felt like I was just doing what she needed because she was going out of town. And she wound up having this gorgeous, like awakening of her ovaries after the pills. And we did it. And not, but it just shows you that like, you can't always predict. You never would have predicted this person would have done well with pills. And then for the next 2 cycles, we always did birth control pills. And she had like really, really nice IVF cycles with pills, even though her AMH was only like 1.0.
So interesting. And how about growth hormones? So I hear a lot of my patients, they come in and one doctor loves them, another one doesn't believe in them. Like, what's the deal?
What do you think about growth? Can you tell me what you think about it, Michelle?
I mean, I've seen actually a benefit. One of my patients had 0.17, I believe it was, which is interesting because AMH does go up and down for her AMH number. And she had a couple of failed IVF cycles, and then we started working together. Of course, the blood flow, the acupuncture definitely helps, and also like the diet. And she did well. She did really well with the growth hormone. I mean, she had 2 embryos, which is, and one, thank God, yielded a pregnancy. And I think she's going to eventually have another one in the future. But that did seem to help. So I don't know. I wonder if it's for some people. I mean, the idea makes sense to me. I'm not sure I understand it scientifically because that's like not what I do, but it makes sense that it would just help them grow.
I mean, there is growth hormone, and there are the receptors there are IGF-1 receptors are like really, at play in the follicles. I have not seen it do anything, so I almost never use it. But I think that what you're just describing with your patient comes in, that's just part of the larger picture and the larger story, which is that, we do sort of, for lack of a better, we empirically do things. Empirically is the medical term for arbitrarily. And, we like, certainly if that worked for her, then great.
Yeah, it's interesting because we're so unique. It's like one person, and then the next one person can do so well on one thing, and then another person with very similar numbers may not respond the same.
Yep. Mm-hmm.
What's interesting too, I find, is that, and I'm sure you see this all the time, is that there's certain people that are like textbook for IVF. And then there's some people that have so many failed IVF treatments and then they get pregnant naturally a couple of times. It's wild.
No. I mean, our bodies were just not meant. I mean, that's also the argument in favor of like, you shouldn't be doing this unless you have to. I think they would have gotten, I do see a lot of people coming in thinking they're going to do this electively. And somehow this has become like the new way to get pregnant. And, or, you're 32 years old and you are married or engaged and you have your partner, but you're just, you don't want to have a baby yet. And I'm kind of like, well, like, why would you do this treatment that's not necessary for you? Like, I do it. I try to talk them out of it. I always do, like, this is a medical problem. And I always try to talk them out of it, and they almost never will be dissuaded. And then it usually goes fine, or at least they get the embryos in the freezer. I think that most of these couples are likely to just get pregnant on their own when they're 36 or 37 and never come back to really need these embryos.
Okay. So there's this one thing that I heard, it's this capsule that goes in. And it basically, I don't know, have you heard of this? It's like this capsule that goes in, basically you grow the embryos inside. You're the lab, probably.
Yeah.
That's interesting.
Yeah.
So what's your experience with that? Yeah.
Yeah. Okay. So InvoCell is a really cool invention where basically when you take the eggs out, the embryologist puts the eggs and the sperm together. So you don't usually do ICSI with INVUCELL, or you're not really supposed to. You just incubate the eggs and the sperm in the little device, and then they tuck it up in your vagina like a tampon. And it's marketed for, for same-sex female couples, so that, like the one who doesn't have the IVF can like also carry the embryos through part of the journey. It also may have a role in resource poor settings where you don't have the high-tech laboratory capabilities and the laboratory staff to run a full IVF center. So I think that it has a role in those situations. I don't think that it's ever going to be better than an IVF lab. But it's, it's really for like good prognosis patients. It's like for a same-sex couple where they don't have any infertility factors, and you know that you're going to have good eggs, and you put sperm in there and they're going to fertilize and you're going to make embryos, and like that kind of situation.
Now, do they use one egg, or can they put a number of them inside?
They can put a number. I think there's a limit, but you can put a number of eggs in there. Yeah, you just incubate them with the sperm and let them grow.
And can they fertilize? Can they freeze it afterwards? Some of them?
Yeah, so that's the thing, right? I mean, that's the thing, is I think there's a little bit of marketing gimmickry going on, right?
Mm-hmm.
Like, it's still IVF, like
Right.
This is not there's nothing natural about this.
No,
You
but
have
it's cheaper,
still have to
isn't it? Because of the lab? Not really?
I mean, right? Like, you still have to get the eggs out of your body.
Mm-hmm.
You still have to prepare the sperm. So you're not just putting like, ejaculated semen in there. You still have to prep the sperm. You have to prep the eggs. You have to put them in the device.
Mm-hmm.
You have to take them out at certain intervals to look at them. You have to figure out, and then if you have multiple embryos, your embryologist is still going to look at your embryos and decides which one you transfer,
Mm-hmm.
and if you have more, if you have extra embryos, you're going to freeze them. I mean, like, it's really just taking the place of the incubator.
Got it. Yeah, just curious.
Yeah.
It seemed interesting when I saw it, and I'm sure there's a lot of gimmicky things everywhere, but it definitely is intriguing for sure. And as far as IUI goes, I've seen a lot of my patients do several IUI per cycle, or sometimes they just do it once. How do you approach this? And it's just, to me, I'm curious as to why some people get several per month and then some people just once.
One. So, and that again is a very personalized decision. So IUI, I want everybody listening to understand that IUI is a far less precise treatment than IVF.
Mm-hmm.
And that's fine. It's less precise by necessity, and because that's how nature works. And when you do an IUI treatment cycle, all you're doing is more eggs, more sperm, good timing, like increase the odds, up the ante, like you want to bathe the ovulating eggs in sperm.
Mm-hmm.
And the way that you do that is by trying to have sperm there a little bit before you actually ovulate your eggs. Mm-hmm. And so now in an IUI cycle, I'm recommending always, intercourse, like frequent intercourse. You shouldn't be saving your sperm. You should be having sex like a lot around that time as well. And then the IUI sperm is also going to be just an extra little boost. And you never know which sperm it is that caught your egg, whether it was the sperm from the IUI catheter or the sperm from at home in your bed. So in that situation where you have a couple, especially if he has reasonable or good sperm count, just have sex and only do one IUI. There's no evidence that more than one IUI in a cycle helps. But you can also but if you have a same-sex couple where their only opportunity to have sperm is the insemination, then maybe, although I will say that I'm like thinking back, I feel like most of my successes with IUIs and same-sex couples have been just with one IUI cycle. And then I think I've done, but then again, it's very personalized. Like I did 2 IUIs recently in someone who is currently successfully pregnant on that cycle because of a number of factors. One is her husband's sperm count was a little bit low, not terrible, but a little bit low. There was some question about the timing of her ovulation. It was like she kind of caught a positive. I kind of did a trigger shot, like we didn't know exactly what day it was going to be. And usually, and sometimes that happens. Like, again, it's not always exact. She also was she'd had a significant surgical history with where I was worried there was going to be a lot of scarring in there, and also she had very low ovarian reserve, and I wanted so badly for this IUI to work because I didn't want her to need IVF because she had when you have very low ovarian reserve, it's always best to try to see if we can get you pregnant inside your own body, because sort of counterintuitively, the fewer eggs you have, the less efficient IVF is. So like getting you I am so proud of the IUI pregnancies I have in people with severe diminished ovarian reserve, where everybody else like, do IVF, when IVF would have been a disaster for them. And so I wanted this to work so badly, and also her insurance was covering her IUIs. So, and they were going to pay for 2 in the same cycle. And I was like, fine, let's do this.
Right.
And she got pregnant on that first IUI cycle. And I was like, great, I'm so glad we did 2. But like, do I believe that 2 really like is important? No.
Yeah, no, it's good to know. All this stuff is really good to know. Another question I have is Clomid versus letrozole. Like, any thoughts on why you would decide one or the other for specific individuals?
Yeah. So these are so remember, first of all, Clomid and letrozole are drugs. They're not natural. They are interfering with your body's own signaling pathways. So you are going to have some side effects with Clomid and letrozole, actually even more than you're going to have even with IVF injections, because IVF injections are a little bit more natural. These are drugs that are like, affecting your brain signaling pathways, talking to your ovaries. They work in slightly different ways, but they are both pills, cheap, easy to take. Now, we have good scientific evidence that letrozole is the first line for polycystic ovary syndrome, with Clomid as a very close second line. On the other hand, we have good scientific evidence that Clomid is the first line for unexplained infertility, with letrozole as a very close second for unexplained infertility. So you can take those 2 things to mean that your doctor can switch between the 2 of them based on whatever their own preferences are and how your body responds. I can't completely control how people will respond to Clomid and letrozole. When you are trying to induce ovulation for somebody with PCOS, the goal is 1 egg at a time. When you're trying to induce ovulation for unexplained infertility, the goal is 2 to 3 eggs at a time. But everybody's body is different, and I can't tell how your body's going to respond until I try it. And so so I do exactly what I just described. If she has PCOS, I start with letrozole. I switch to Clomid depending on how her body does. If she has unexplained infertility, I start with Clomid and switch to letrozole depending on how her body does.
Got it. Interesting. Well, I mean, it was so nice to get all these questions that I had answered. I mean, I definitely learn a lot just through my patients and what they're telling me, and also just my own research. But of course, this is not my expertise. So it's really great to actually speak to an expert. And also to hear that there's so many different ways to approach this, and that's why it's so important to really talk to a number of different doctors and really find somebody who's aligned.
For sure. I was going to ask if you could teach me something that I could implement in my practice today.
That's a good question. Let me think. I mean, you had mentioned something that I like, to be a team with your patient. That's something that I hear very often. A lot of my patients talk about, and it really is a game changer, I think, in their experience when working with their doctors. And I have some doctors that are very nurturing and really do explain things to people. And I think that that's huge. That's just what I hear, the feedback that I hear from my patients. I don't know if you want to hear something more of natural.
Yeah, sure.
I could definitely tell you something. There's some interesting evidence-based information. So one other thing that I was going to mention is earthing. I always recommend for people to earth. There is evidence that it lowers inflammation in the body. which, as you know, is huge for fertility health on so many levels. So I do like mention to people or suggest that they put their feet on the earth or get a grounding mat
I love that.
to lower inflammation. And it is something, actually, if you watch the Earthing movie, it's a game changer. It's amazing. And it talks about it, and it shows a thermography that really shows within 15 minutes of somebody putting their feet on a grounding mat
Mhm.
that their inflammation lowers. It's really fascinating.
I'm going to look into that. That sounds, I'm like sitting here kind of wiggling my toes in my shoes, wishing I could be on the earth right
Yes.
now.
Yeah, and it also helps with sleep, which, as you know, is important just overall
Yeah.
for hormone balance and so many different things and stress relief. And so that's a huge one. And then I was going to ask you, do you suggest melatonin to your patients?
Yes, I do actually. I love melatonin. And
Mm-hmm.
I personally think that it's definitely my drug of choice to get a good night. Or it helps me actually not wake up early in the morning, like with racing thoughts, you know. Um,
Mm-hmm.
but no, melatonin actually has some evidence-based benefits for fertility, and I do recommend it to people, and also especially when people even just to take the edge off of some of that anxiety that they're feeling, understandable or emotions that surrounding this process to help them to get a good night's sleep and relax.
Absolutely. And another thing, so there's melatonin that you get in your bloodstream. It usually comes from your pineal gland at night, but melatonin, cellular melatonin, which works as an antioxidant for your mitochondria, which helps with egg health, comes from the sun. It comes from the infrared light.
Mm-hmm.
So I always suggest, and this also helps with anchoring your circadian rhythm and also helps with sleep at night, is getting early morning sun.
Yeah.
If it's early in the morning, my grandmother used to tell me this all the time. She's like, early in the morning, you get like all the benefits from the sun. You get all the vitamins, she used to say.
Yeah.
And it's true. It's not as dangerous. You don't have the UV light, which is the more dangerous, which increases during the middle of the day.
Right.
But if you do it early in the morning, and then sometimes I even say expose your belly, your abdomen
Mm-hmm.
early in the morning. And if it's early enough, obviously it's safer. So that's one of the things that I do. It's kind of like one of my prescriptions is getting that sunlight in the morning, putting your feet on the earth, and doing some breath exercises outside. But all of these things to anchor us to nature, which always has our back, right?
Yeah. That sounds amazing. I'm definitely going to look into that. I think that also just to sort of maybe tie in along with what you're saying about all of those self-care and self-nurturing and self-grounding kinds of things that you're talking about is I'm really, really big on making sure that patients understand that they they have to they have to live through this. They have to live their lives with
Mm-hmm.
and not let this be all consuming or take over everything. And they deserve to live a rich, rewarding life in every other area, and not put all of their thoughts and energy into this one thing. And so I'm really big on also trying to make sure that I support patients in that area, even as they do treatment with me.
I love that. I think it's what you just said is so important. Not to shelve your well being until, I think it's a human condition that we kind of put things off or our joy, and we can't be happy until. And it's so important to continue living your life. Absolutely. Not only is it important, but it also feeds your process. And it's so nice and refreshing speaking to you. I feel like you're so aware and nurturing in your process, but you're also like well balanced in your approach. And it's really nice. It's really nice to hear. You sound like a good doctor to work with, like probably really helping a lot of people going through this journey because it can, as we know, it can be so stressful.
Yeah. I was looking through some of your previous podcasts, and I think that you have such a nice balance of all of the different adjunct things that people can do together with their fertility care. And if, we've only barely scratched the surface of things that we could have talked about together today. So if people have more in-depth questions, they're welcome to ask them, and we can be in touch and answer them again in another format.
Yes, absolutely. That would be great. Yeah. And by the way, you guys got to check out, is it your Instagram or it's the clinic's Instagram? But you have like a lot of really good information there. I love your little videos, and I definitely highly suggest anybody who's really going through the fertility journey in general. It doesn't even have to be IVF to check it out.
Yes, we're working on it. I've been so busy with direct patient care, which is really my strength and what I enjoy doing, that the Instagram stuff is hard to keep up with. But we are definitely trying, because what I want to do is make sure that my message and my voice is clear in all of our marketing, in our messaging, that you can tell I'm going to address the hard stuff head on, and not mince words, and not skirt any important issues that we have to talk about.
Yeah, I mean, I found them very helpful, so I think people should still check it out. But if people are interested in working with you and live Los Angeles,
right in the middle of LA, in Century City, yeah.
Okay, so if anybody's in that area is interested to work with you, or people are just curious to find out more about you, how can they find you?
Sure. So our website is where the practice is Beverly Hills Fertility. The website is beverlyfertility.com. When Beverly was my grandmother's name, so I really just like that that's the web.
Oh, that's nice.
And our Instagram, Beverly Fertility, my Instagram, Dr. Goldstein. Also, people should check out the resource fertilityiq.com, where patients can write honest, detailed reviews of their own experiences with their doctors.
Awesome. Love it. This was such a great conversation. I'm so happy we spoke, Dr. Goldstein. This was really, really beneficial, I'm sure, for so many people listening. So thank you so much for coming on today.
Yeah, you're so welcome, Michelle. I really appreciate the invitation. Thank you.
So that concludes today's episode. You can find all of the links mentioned on the episode notes. If you're enjoying these episodes, please take a moment to share and leave a review. Reviews mean everything to podcasters, and I really enjoy hearing from my listeners. You can also find me on my website at www.thewholesomelotus.com, or email me at info@thewholesomelotus.com. I love hearing from my listeners. If you're interested and want updates as well as a free ebook on my top 10 fertility boosting habits, you can visit my fertility page on www.thewholesomelotus.com. I thank you so much for listening in, and hope that you have a beautiful day.